All right, yes, good morning, everyone. I hope, everyone's enjoying their March break, if they're not at work. Um, Welcome to my presentation today. It's a kind of an extension of a topic that I've briefly touched on beforehand, but wanted to talk, given the relevance that I'm on CCU now, and I've used this a lot on call in terms of bedside ultrasound use, in particular for some kind of peculiar diagnoses that have come up in the last 3 to 4 weeks that I've been on call, that I'd like to share and wouldn't mind everybody's participation to see what kind of diagnosis that they think is present. And then the second being a review of using the point of care ultrasound for volume and hemodynamic assessment, which is becoming more and more of a tool both in ICUs, in emergency departments, and in our CCU or cardiology ward. All right. So I'll try to make this as organized as possible. I don't have any disclosures. I'll try to keep this both organized and succinct and concise because Pocus has become a huge topic, just like ultrasound is in general. For the most part, we're going to focus mostly just on transthoracic use of ultrasound, particularly when it comes to just the heart, as there's a number of different modalities and anatomy that's used for bedside ultrasound assessment. Traditionally, we all understand this being used for procedures in the last 10 to 15 years. For IJ access and central line access, but it's being used more and more now by clinicians for making, in conjunction with their physical exam, bedside assessments and decisions for management of patients in both acute care medicine and in the emergency department. Now, the great thing about bedside ultrasound, it can supplement our physical exam, but does not replace it. And it provides some objective real-time data, as well as real-time imaging data that we would not otherwise be able to gather. It is quite cheap and accessible, and is present in most hospitals now. And people can buy even their own personal devices to kind of keep in their pocket, such as the Butterfly or Philips Venue machines, that really allow for kind of pervasive use, both in hospitals and environments that are really low resource, but also in very high resource environments, just like St. Mike's or where I am right now at Sunnybrook. There's still a lot of emerging evidence. There's no randomized controlled trials or anything that shows support for or kind of any of the steps that I'll walk through, but it's starting to show some strong evidence for that, at least provides, in addition to a physical exam and other metrics that we use for diagnosis, support. Now, there's a number of limitations when it comes to bedside ultrasound that I do want to highlight before kind of going through these different hemodynamic and volume assessments. One is machine capability. It's very in a range from some of the handheld devices to some of our larger devices, in contrast to our large echo machines. It really depends on the user, both in terms of the familiarity of using the device, but also in terms of acquiring appropriate views. And not only acquiring appropriate views, but also making appropriate interpretation based on the images or data that they gather. And when it comes down to the patient, it's very important, particularly in an ICU type environment or CICU, that we understand if the patient is spontaneously breathing or mechanically ventilated, if they're on positive pressure ventilation like the mechanical ventilation or BiPAP, or if they're just under regular spontaneous negative pressure ventilation. And whether or not they have other kind of pathology that's going on, whether it be pericardial pathology or cardiac pathology that we're looking at, or if there's other issues that are going on in a patient who's post-surgical per se, when it comes to abdominal pressure, increased ICP, and of course the patient's body habitus. The main learning objectives that I wanted to focus on today and to highlight and walk through with you is first, what are some of the diagnoses, as well as hemodynamic measurements that can be determined using bedside ultrasound or echo. The second would be discussing how a patient's fluid status and volume status can be measured when using Pocus. And third, which may be a little bit unfamiliar for many of you, would be describing the Venous, what's called VExUS score, which is related to what's called Venous excess ultrasound score, and explain how that's performed and why it's used, as it is also a metric for determining patient's volume status in an ICU environment. So focusing on learning objective number one, I'm first going to walk you through some diagnoses, and this is all from bedside ultrasound images that I obtained over the last couple of weeks from in the CCU or on call. And if anyone would be really happy to appreciate if you had any, and hopefully this plays for us here. So this was a 55-year-old gentleman who showed up after having 2 weeks of chest pain, came in a bit short of breath, elevated JVP, with a murmur auscultation and a late presenting STEMI. There was no comment on murmur or anything like that from the preliminary assessment by EMS or by the emerge team. And this was his bedside assessment. I'm not sure if anyone wants to can see here. I think it's pretty obvious that there's a large ventricular septal defect, kind of distally along the inferior septum. And this patient had a urgent kind of balloon pump, and then was stabilized and brought to the OR. I had a case recently here, as you can see, just on bedside for a patient with chest pain in a 27-year-old. These are two different cases. You can see there's a large kind of extracardial, pericardial or extracardial mass with a large pericardial effusion, and some concerns for possible. I think in other views the patient wasn't tapped. It did get tapped, and it turned out to be a rare form of sarcoma. We had another recent case for a patient that came in short of breath with left-sided heart failure symptoms just 2 weeks ago, and this is from a large left atrial myxoma that was causing inflow obstruction to the mitral valve. I'm sorry, these are supposed to loop. We had case presentation as well for, unfortunately, a lot of tumors recently. This is a young gentleman with melanoma on the right side here, who presented with a large mass in his RV, which is being worked out for either metastatic melanoma and/or thrombus. And he had presented with short of breath and positive D-dimer, and was picked up with concerns for pericardial effusion by the emerge team. On the left side here was a case for a patient that actually had came in with acute MI and STEMI, was revascularized, but just on bedside assessment, had this kind of right atrial presentation, which most people thought was a eustachian valve, which was quite profound. And then also in terms of the utility of bedside ultrasound when it comes to assessing patients that we have for heart failure presentations or hypotension, and the utility of it assessing for LV function. On the left here is a patient who was a 50-year-old gentleman with non-ischemic cardiomyopathy who came in with cardiogenic shock with severe dilated cardiomyopathy. And then the second was a case actually from 2 days ago, from a little while ago. This one, it was my better image, but it was a patient who had coded on PEA arrest and secondary large RV failure, and was found to have a new diagnosis of scleroderma that was never diagnosed, and clearly had RV failure with severe pulmonary hypertension. And also the utility, we've had a number of cases of endocarditis in the last couple of weeks that we have found on bedside ultrasound imaging with large vegetations, in this case on the aortic valve on the left, and coincidentally just another mass in the interventricular septum, which was a lipoma on the right side. So just wanted to highlight that those were cases that provide a lot of utility in terms of providing some quick peculiar diagnoses that have happened just for the most part in the last couple of weeks, just on bedside assessment for patients that come in with a variety of common cardiac complaints, and how that might be able to expedite some of the diagnosis and hone in our differential and the utility from that. And I think we're all aware of that. I wanted to kind of focus the rest of the presentation more on the ICU care in terms of the supplementation of hemodynamic and volume assessment and volume responsiveness for patients using bedside ultrasound. So hemodynamic assessment will divide into both static evaluation, which is mostly from all of the measurements that we have from traditional transthoracic echo, and then we'll get into dynamic assessments, which is related to volume responsiveness in the second part of the talk. To keep it somewhat interactive, I find it very difficult just talking to a computer on Zoom. I had a few questions that I wanted to see, and hopefully everybody can answer. Feel free to put in the chat. I don't know if the chat will actually pop up to me, but it would be great if you could participate. So, in the first question here is, which of the following measurements cannot be estimated from a bedside ultrasound assessment? And from the number of options here, related to the pulmonary pressures, both diastolic or systolic, you have the pulmonary vascular resistance, stroke volume variability, all the above or none of the above. And just for time's sake, I'll kind of move on. It's none of the above. Um, all of these metrics can be gathered. Of course, the accuracy of them really depends on the quality of images and data that you gather, but they can all be at least measured directly or can be estimated using the known parameters that we're familiar with to calculate, including the PVR. When it comes down to hemodynamic measurements, divided into 8 main topics, and we're all very familiar with these hemodynamic measurements. I'll focus first on the right side and then on the left side of cardiac measurements, starting with the CVP. And just to give you a brief overview in the same respect, a lot of this is what we're determining and measuring related to pulmonary arterial catheters, which would be our gold standard for hemodynamic assessment and is more invasive. We do use this in the Toronto General ICU, and we're starting to try to use ultrasound a bit more to see how related these two measurements are. Again, mostly with PA catheters, we're directly measuring these pressures using the catheter in the intracardiac chamber, and then directly measuring or calculating the relevant values as such. In contrast to echo, which we're all familiar with, including on bedside assessment, we have an estimate for these measurements based on Doppler signals and flow. And I'm going to walk through all of these different ones on the far right side with you. So number one is the CVP, which we're all familiar with, or the right atrial pressure. And this is related to the IV size and collapsibility. So as we're very familiar with, the RA pressure can be estimated by using the IVC diameter and collapsibility with inspiration or a sniff test. We have measurement thresholds of 2.1 centimeters and a collapsibility index of about 50%, whereby we then have an estimated right atrial pressure of 3, 8, or 15 millimeters of mercury, depending on that. We all routinely probably use this as the most common modality for a static hemodynamic and volume assessment for patients, which is something that's becoming a little bit more used ubiquitously. And I think we're all familiar with this. In some ways, there's not complete standardization, but traditionally it's about 1 to 2 centimeters from the junction of the right atrium that we want to make this measurement from. We have to be cognizant of the kind of the cylinder effect and understand the proximity to the hepatic vein as well. Oftentimes, we find that there's some issues in terms of people who are less familiar with using bedside ultrasound, that they try to measure the IVC, but often lose the short axis on inspiration, and it really requires maintaining that cylindrical effect to be able to get the full diameter. This is just a static image, because we've all seen this before. It can be measured in M mode or on 2D echo. Some of the newer devices will have an auto IVC measurement feature, which will try to measure out the IVC and dynamically measure it with inspiration and expiration automatically for us, which helped make it a little bit more ubiquitous as a measurement tool. Again, the most important caveat is this is for spontaneous breathing patients. It's not validated in patients on positive pressure ventilation. There are some studies that do demonstrate that TE could be used to demonstrate estimated CVP for patients who are intubated on mechanic positive pressure ventilation, but it's not really been used very pervasively. The second we all know is to measure estimate at least the systolic pulmonary arterial pressure. We use that with the RVSP, which we're all very familiar with. In terms of referring this to the right atrial pressure that we just estimated beforehand, to the extent of tricuspid regurgitation. Of course, we have caveats and limitations that we need to be aware of in the context of severe TR, the spectral Doppler signal that we're able to obtain from the TR jet for patients that don't have any tricuspid regurgitation at all, and if there's any RVOT obstruction or pulmonary stenosis. And I think everybody's very, very familiar because we do this on the measurement echoes, but it also can be done at the bedside, and it can be done with a number of the machines that we all have to also kind of estimate what our pulmonary pressures are as well. We can do the same actually for diastolic pulmonary arterial pressure, although less commonly measured, at least with our routine echoes, but can be done at the bedside as well. We use this by looking at the end diastolic pulmonary regurgitation velocity with the continuous wave Doppler. It does require a bit of PI and a good signal across that Doppler signal. And we use the similar, very simplified Bernoulli equation as well. And we end up adding that to the right atrial pressure. So our equation is very similar to for our RBSP, where we take 4V squared, where V would be the end diastolic pulmonary insufficiency velocity, and squared, and we add that to the right atrial pressure to give us a estimated diastolic pulmonary arterial pressure. And this is blown up here, and we're very familiar with measuring this at end diastole. The second question I had was which of the following dimensions are required to estimate the mean pulmonary arterial pressure by echo? So we have IVC collapsibility, RVSP, the RVOT acceleration time, or A and C, or all of the above. Yes, that's a good point, Dr. Chow. It does require that. A number of the new machines do. I know even some of the handheld ones are starting to obtain that. Some do not, but almost all ultrasound machines that we have mobile on the stands do have both PW and CW. They might not have tissue Doppler though. And so here this is A and C. When it comes to the mean pulmonary arterial pressure, we can measure that using the RVOT. Again, yes, you do require the pulse wave signal. And this is where we basically are taking the acceleration time of the RVOT pulse wave signal. Depending on the duration of the acceleration time, there's two different equations. Hence, there might not be complete validity of how valid this is in terms of the quality of the signal, but it is a reasonable measurement to try to estimate at least. The theory behind this is that as the pulmonary artery pressure rises, the compliance decreases, and that must be reflected in the pressure wave of the RVOT acceleration time through that jet. Now, it does reasonably correlate as long as you can memorize these equations or have a quick calculator to use this with you. And essentially, we just calculate with the slope, similar to an acceleration time on our pulse wave across the pulmonary valve. If we can get good enough signal in the basal short axis view traditionally. Another way to also calculate this is to just take the estimates that you had from your RVSP and systolic pulmonary arterial pressure and to your diastolic pulmonary arterial pressure that we talked about before with the PI and diastolic velocity, and using the similar parameters of 1/3 the systolic pressure to 2/3 of the diastolic pressure, you can also be able to calculate to give you a rough estimate. And again, we can actually calculate PVR for these patients just using the pulmonary arterial pressure waveform and the cardiac output measurements that we also derive from other echo measurements, similar to how we use for a pulmonary arterial catheter. When it comes to left atrial pressure, I won't focus on this too much because we do this for all of our routine echo studies, and that's looking at diastolic function and the E to E prime ratio. Can be used as a surrogate. Again, there's many caveats that we'll get into, but a surrogate for the left atrial pressure in terms of whether it is less than 8, greater than 14, or between 8 to 14, where it's indeterminate. Most contemporary Pocus devices are starting to be able to perform tissue Doppler, as well as pulse wave, at least. There's a few devices that don't have tissue Doppler, which makes this very difficult. But it does at least open the opportunity for practitioners that are a little bit more in tune to using bedside echo to be able to start doing diastolic measurements in the appropriate context. And this is all very familiar to us, so and just for time's sake, I won't go through it completely. But this has been used in a few studies when it comes to guiding diuresis, in addition to using the CVP. And it can also provide some causes in terms of pulmonary edema or pulmonary hypertension. So it can be a helpful thing to measure even at the bedside, or we're a little bit we get formal echoes to assess patients in terms of their volume status on a day-to-day basis. And if we're able to get these measurements and do these calculations quickly, it may provide us with some helpful real-time information to supplement our physical exam, particularly for patients that the physical exam is difficult or they've been difficult patients to manage for their heart failure in the relevant environment. And we're all very familiar with this chart in terms of diastolic dysfunction and estimated left atrial pressure that we routinely measure with all of our standard transthoracic echoes. And of course, we have a number of limitations that we are also all aware of, particularly when it comes to patients with valvular disease, regardless of whether it's mitral stenosis or moderate to severe MR, prosthetic mitral valves, certain pericardial diseases, and of course, a significant mitral aortic calcification. Now, stroke volume can also be estimated. We're also familiar with this by using on the left side of the heart, using the LVOT VTI. And this, of course, also requires a pulse wave signal and calculating the area under the curve. We then are able to then estimate cardiac output index or cardiac index based on the body surface area by multiplying that by the measured heart rate. So those were the static measurements of hemodynamic assessment that we're also able to do on our common transthoracic echo, although it's not as common to do some of the pulmonary arterial measurements for those. I just wanted to highlight that a lot of our bedside machines can do that as well. So on a day-to-day basis, it may provide us with additional information for making patient decisions, in addition to the information that we have from an echo from previous days ago, or for patients that we need to see an assessment in the ICU or the emergency department overnight. The second learning objective I wanted to focus on was discussing how fluid status and volume responsiveness can be measured using bedside ultrasound as well. And this is really going to get into more dynamic evaluations. Largely more relevant in some ICUs when it comes to septic shock and distributive shock, where they're giving volume, but can be just as relevant when we see patients to determine whether they're either euvolemic, dry, if we ever want to give them a trial of volume, or if we think that they're actually hypervolemic, which are most of our patients. In this respect, what is this estimated pooled sensitivity and specificity for the volume responsiveness based on IVC collapsibility? And just from the options here, I'm not sure if anybody's familiar with that. So the sensitivity is about 60%, specificity about 70%. It's not a perfect test, but it's reasonable. And again, with the limitations that we discussed before, it's important to keep those caveats. A lot of people just use the IVC measurement and kind of walk away, but we have to use that with all of our clinical information to make determinations about volume responsiveness. Again, the thing with IVC measurements, it's a static measurement, and we use that with some caveats to estimate the CVP. We can use the other static measurements, including the left atrial pressure estimate from the EDE prime and diastology appropriate. And if we have measurements, would be the LV and diastolic volume as well. We can use these static measurements to help determine whether or not somebody requires more preload, or if they believe that they have too much preload, and then whether or not they'd require additional volume for that. Now, the dynamic measurements come into play when we have regular breathing and spontaneous breathing, when we have different indexes and different variants of measurements that we can do. So the dynamic measurements that I'm going to focus and talk about now are related to the collapsibility index for the IVC or the SVC, what's called the pulse pressure variation or stroke volume variation, passive leg raise, and the mini fluid challenge. So with normal inspiration, we all know the IVC collapses, the SVC distends. This is the opposite in somebody who's on positive pressure ventilation, hence why IVC measurements in patients who are mechanically ventilated are not validated. And it's because it's the opposite, where the IVC will distend and the SVC will collapse. Now, if you put the pooled sensitivity between those, it's about 60 and 70% respectively, and determining whether or not this patient could be appropriate for volume, whether it be euvolemic, could respond to more volume, or hypervolemic. There are some situations where we can have false positives and negatives, and a lot of this is exactly why we also need to use our full clinical judgment and physical exam to look at. Again, not coached spontaneous breathing can sometimes lead to false positive or negative, depending on the respiratory variability of the patient, as well as extreme respiratory effort can alter the intrathoracic pressure and cause altered measurements, and things like pericardial disease such as tamponade or severe RV dysfunction, which is more limited utility for patients that we're dealing with RV failure. When it comes to stroke volume variation or variability, We don't usually calculate this, but this is something that we can actually do at the bedside. Again, this requires pulse wave signal over the LVOT and calculating a VTI as a surrogate for a stroke volume. A 10%, 10 to 15% difference in this variation is what we're looking for. And similar to how we looked at the inflow velocities traditionally when we assess pericardial effusions over the mitral and tricuspid valves, we're doing basically the same where we increase the scale and the time frame of the Doppler signal and compare the maximum in min across that, and using kind of a simple calculation for the variance. It's a bit difficult to memorize, but there's a number of calculators that we can have on our phone. We can then basically find a difference between those to give us a variability between our stroke volume from a beat to beat. This has reasonably good variability if you look at area under the curve for patients that would be volume responsive. And a point to make with respect to this too is the fact that some of the machines can actually calculate this for us directly and kind of give us a delta percentage. A 10 to 15% difference is what we're kind of looking for patients that would be volume responsive. Now, the caveats being, of course, if there's PVCs, that it is helpful. And some of the echo machines can do this on the bedside, is put ECG strips on. I know the Mindray devices can, and some of the GE devices as well, to ensure that we got appropriate electric and mechanical contraction that we're making these estimates from. And at the same time, making sure that, of course, of the patients in AFib, there would be more variability as well. In analogous to this is the pulse pressure variation. And pulse pressure variation, we can see both on arterial waveform and is basically analogous to the LVOT VTI. We're basically comparing the max and mins, where we subtract the difference at the top, we add and divide by 2 as the denominator and times by multiplied by 100 to give us a percentage. And again, that 10 to 15% range is what we'd be looking for. Now, the problem is many of these patients that have been studied when it comes to using pulse pressure variation and the LVOT VTI variation for stroke volume variability, a lot of it is based in ICUs rather than in cardiac ICUs. A lot of these patients are heavily sedated on propofol. Some have received chemical paralysis with rocuronium, and most are on pressure control or volume control settings where they're not triggering a breath. That makes things difficult in terms of the validity for many of the patients that we see who are now spontaneously breathing, as well as some of the cardiac patients that we see. And so as such, a lot of this is more used in ICU environments where patients have distributive shock. There are some inherent limitations that I had mentioned if patients are in atrial fibrillation or any other kind of arrhythmia. If there's frequent PVCs, it's difficult for this to be able to measure. Lung compliance become an issue, as well as abdominal pressures, particularly for patients who are postoperative as well. Now, one that we can do also at the bedside, and sometimes is used more historically, has been passive light raise. And we can use that and also that with our echo findings to provide us kind of like a fluid challenge, similar to providing a small bolus of IV fluid to see if patients are going to be volume responsive with us. Sometimes we do this and we measure the blood pressure. Sometimes we can actually do this and use our same measurements and analysis with the bedside ultrasound in terms of stroke volume and pulse pressure variation to make that decision. This has been essentially used in patients who are on dialysis in the ICU or who are receiving diuresis, particularly mostly validated for patients with, again, distributive shock. Now, we can use this with calculating both the stroke volume variability as well as the cardiac output variability, which actually has a quite strong sensitivity and specificity, and it's probably our best dynamic hemodynamic volume responsive assessment with a great likelihood ratio of +11 if all done properly. Essentially, what that involves is someone doing a bedside ultrasound, either a TE or transthoracic echo, at the same time lifting up both legs with the patient being supine for at least 10 seconds and holding them there, and then measuring the difference in the cardiac output or the LVOT VTI or any of our other metrics that I kind of discussed already, and then based on that to see if the variability has changed. Again, the same numbers, about 10 to 15% in terms of variability, provides enough to say that there's probably volume to be given that the patient would respond to. The reverse would be said if the patient is likely hypervolemic. Another, just an analogous to using LVOT VTI, the carotid Doppler VTI can also be done. I'm sure a lot less of us are familiar with this, except I'm sure some of the our excellent techs who do vascular ultrasound. We can do the pulse wave of the Doppler across the carotid. When there's very similar surrogate markings, with the caveat that there's no aortic stenosis, LVOT obstruction, or significant flow-limiting atherosclerotic disease. There's a lot of ongoing research for this, given that this is much more accessible in terms of views, particularly because it's on the neck rather than on the chest, based on patient body habitus. If they've had surgeries, we have pads or stickers on their chest as well. And so this might be very, very similar in terms of the metrics that we can achieve as well. Similar and analogous to this, we can also do IVC collapsibility using just the JVP with the linear probe over the neck as well. There's new time indexes that have also been measured. There's not as much data research into this, but it's kind of a new and up-and-coming thing that we see in a lot of, we'll see, emerge Pocus blogs, as well as a few papers in terms of trying to find other things that we can measure when it comes to carotid Doppler signal, given just the accessibility and ease of obtaining a good measurement. And this is just in terms of how it's performed. We all know how to get vascular access with usually for the IJ for a procedure for a central line. This case, we're just focusing now actually on the carotid artery. Based on that, we can get a Doppler signal and compare both the flow across that in terms of the velocity and the time and the variability, beat to beat, or we can use this time index, which even some of the ultrasound machines are able to measure in and of themselves on their own. Just to summarize now, we have the different methods I kind of discussed in terms of assessing fluid responsiveness, whether it be related to stroke volume variability. We have this SVC distension or IVC collapse and those indexes. We have the passive leg raise, and then the mini fluid challenge, which is analogous to our passive leg raise. As I just kind of discussed, big caveats being patients are in atrial fibrillation or frequent PVCs or some kind of irregular rhythm, whether or not they're ventilated or spontaneously breathing, and whether or not their lung compliance, particularly given that a lot of these studies are on patients who are mechanically ventilated with sometimes pneumosepsis or with lung disease, whether or not their tidal volumes and lung compliance are appropriate. The thresholds kind of fit all around 10 to 15%, and we already know that IVC is about has always been 50%. Now, different things I want to talk about, I kind of use the term full volume responsiveness. That really depends on what context we're using. Whether or not the patient will be fluid responsive is very different than whether the patient is fluid appropriate. As given that this is just some information, we have to use that with all of our clinical judgment, physical exam, and other diagnostic tests and investigations to determine whether or not the patient is actually suitable for taking on more fluid or for taking off fluid. At the same time, we also want to know whether or not the patient is fluid tolerant. And this is where this new metric VExUS and the VExUS score comes into play. And I believe there's some studies, I think, that were being done even at St. Mike's recently, because I remember that we had a sheet going out last year. And this is kind of the third objective that I just wanted to focus on for the remaining time. So one of my last questions is, what are the components of the VExUS grading system, if anybody is familiar with it, just to get a kind of sense of a baseline? All right, so it involves the IVC, which we're all familiar measuring, the hepatic Doppler, which we're also familiar measuring, and a few other Doppler signals that aren't as common to us as cardiologists or sonographers. There's the portal vein Doppler, as well as the intrarenal venous Doppler. Now, a lot of this research has come from Quebec, and there's a lot being studied from this, particularly in patients post-cardiac surgery, as well as in medical ICUs.
Um, Yesterday, I think we had a record of contrast because I'm pretty sure we went through at least 4 vials, maybe 5 vials of contrast yesterday.
Sorry about that. So there's a number of actually original articles that have come out in the last couple of years. There's many more new ones from this, is trying to quantify systemic congestion for patients that are considered to be volume overloaded or over resuscitated. Not just looking at just the heart and the static measurements or the dynamic measurements that we can measure from that, but also looking at where other congestion underlies in the body, whether that be in the hepatic system and the renal system. So essentially here, instead of looking at just the heart, we're actually just going to be looking at the liver, gut, and the kidneys. And we're trying to determine a lot for patients with septic shock, but it's starting to be used mostly in medical ICUs and post-cardiac ICUs, again, as a diuretic plan for patients with CHF, and measuring to what extent that in some cases, diuresis is complete. So in terms of doing this, it requires us scanning the patient's right side while supine using the curvilinear probe rather than necessarily the cardiac probe. We can also use the cardiac phased arrays probe as well, and use this as a abdominal preset rather than the cardiac preset. You do require pulse wave Doppler for assessment, and again, most machines are able to provide that for us. It requires really good landmarking and really good being able to find the appropriate anatomy. And that can be one caveat from this because these are much smaller vessels that we're looking for. The first step that we're going to do is measure the IVC and its collapsibility, which we're all very, very familiar with. The second step is then we're going to focus on the Doppler hepatic vein, the hepatic vein, which is, of course, right at the same level of where the IVC is, and do pulse wave across that. The third step is then to find the portal vein. And last but not least, we'll be finding what's called the intralobular or intrarenal veins. Over the assessment of the hepatic veins that we're familiar with, we get the 2D, then the color Doppler signal. We can then put pulse wave over this and see our pulse wave waveform, and this would be our normal pattern. We are familiar with the S&D waves and the pattern of looking at flow reversal in the hepatic veins, and we often comment on this when we're looking at patients with right-sided heart failure and RV overload. And at the same time, once we're in a similar area, we can actually find the portal vein. Oftentimes, this is used best when we're actually put the ultrasound probe on the patient's left side, and that way we have better access to a direct signal over the portal vein. We get a Doppler signal, which should be flowed towards our probe in red, and then we have a much different types of Doppler signal here. This is being normal, which is pretty flat. What we see here when it comes to abnormalities with the portal vein, and some of our songs might be more familiar with this than I am in cardiology training. But again, we're just measuring the variability of this across the cardiac cycle if we can put the chest leads on. And this, we're looking for variability between 30 or 50%, comparing both the max and the min across the cardiac cycle. And when we see that there's more congestion, there's significantly increased variability between the maximum and minimum distensibility of that pulse wave signal. The intralobar vessels of the kidneys are much different. Again, this can be done best with the curvilinear or phased array probe on the right flank of the patients, just a bit inferior, just a bit caudal to where we were just measuring the portal vein. And here we're trying to get a Doppler signal of in this case, the red. So this is in terms of the veins going towards the outer layer of the kidney. And we'll get a signal here that's provided as probably both arterial and venous, because it's hard oftentimes to be able to isolate one and not the other. In the case of the VExUS score, what we're basically doing is looking at whether or not there's this diastolic phase or there's continuous monophasic flow, which is traditionally what we're looking for. And again, that's related to the venous system because we're looking at congestion. So if we look at the underneath our baseline, the bottom Doppler pulse wave Doppler signal should be about monophasic. In patients that have severe intrarenal vein abnormalities, we see this only diastolic phase flow. which kind of suggests flow reversal, which suggests more congestion in the kidneys, which in the parameters of using with our other portal vein, hepatic vein, and IVC can suggest even more so strongly that there is increased congestion. This is a good summary diagram that they have put in this paper, with the green being normal, the red being severe. We're familiar with the hepatic vein Doppler in terms of what a severely abnormal flow reversal would suggest with their S and D waves. We have our portal vein Doppler, which a few will be less familiar, but to suggest that in normal, it's really monophasic. In severe, we see this almost parabolic or biphasic pattern. And when it comes to the intrarenal venous Dopplers, we're looking below the baseline. We see that there's S and D waves across the cardiac cycle, but this is D wave predominant, given that it's mostly all diastolic flow reversal. We take these measurements and then we can provide grades based on what we've measured in those four aspects. And that kind of gives us a grading scale. We have very familiar just using the IVC alone, but using these in conjunction can provide us with maybe a little bit more accurate information to what's exactly going on. Traditionally, once we get to the IVC, we know what our grading scale is. We're very familiar with this and how it relates to right RA pressure. And this time we're combining that with what our other metrics show. So for IVC is normal, I think usually we're just saying done. There's no need to measure everything else. If our IVC is abnormal, when we're suspecting RA pressure of 15, then we can use any combination of any of the abnormal patterns of the other measurements, which suggest maybe grade 1 or mild congestion. And then skipping down to grade 3, where we have severe, we have an RA pressure of 15, and we have two other severely abnormal patterns. And so that might suggest for patients that perhaps are also intubated, sedated on mechanical ventilation, where IVC isn't maybe as accurate, and validated that these other metrics might be a little bit more helpful in determining patients' volume status. And this is a summary of that that's found in this paper by Bouvier. So all in all, I think it provides a VExUS score is a kind of a newer tool that a lot of ICU physicians are using when it comes to resuscitation or diuresis endpoints. It helps us provide some information of not just what the IVC or the JVP is doing, but also where congestion in the liver or renal system, to provide us with some more information that might provide us with a little bit more support in one way or the other. A lot of this came from, again, just to summarize, is from post-cardiac surgery patients, particularly with patients who developed AKI, and trying to prevent renal injury and appropriate volume management for patients that are difficult to assess on a real-time basis, and where we're using a lot less pulmonary arterial catheters and invasive management. I want to leave some time for questions. So just going to skip through this at the end in terms of these are kind of our valid studies with respect to all of this, which is mostly from Montreal and Quebec, who's provided us with a lot of information with respect to this. I'm not sure if anybody has any kind of familiarity using this at the bedside. I know there's some in some studies that kind of doing locally with respect to this. So just to summarize again, on bedside ultrasound, we have a lot of hemodynamic measurements that we're comfortable doing on transthoracic echo with our main machines. Some that we don't do as routinely. There's static measurements, but they can also be done at the bedside with a lot of the devices that are accessible in our ERs, in our CCU, or on the ward, or our handheld devices. We have also a number of strategies that we can use to estimate volume status and volume responsiveness dynamically, which we can start to use more to supplement our physical examination and other investigations, and provide us with some opportunity to use non-invasive imaging at the bedside rather than invasive techniques for determining volume responsiveness. And the third is that we can use other measurements which are simple enough and are analogous to the measurements that we already know for measuring IVC or the hepatic Doppler flow, but extending that to the portal vein or the renal system to provide us with another adjuvant and adjunct information that can also be helpful and supplement all of our clinical information for determining patients' degree of congestion and continued diuresis. These are some of the references I used. I also had kept references throughout for all my slides, which I'm happy to share. If anybody had any other questions, I'd be happy to try to answer them. And